What's up, everyone? Welcome back to the What's True Health podcast. This week we have Daniel Arbilla once again. I'm sure you're very familiar with Dan by now. He's been on the podcast multiple times, so he's a friend of the show. Welcome, Daniel.
Thank you for having me again, times three, I think
Yeah,
now.
3 or 4, something like that.
Yeah. Soon I'll just take over. I'll start hosting. You'll be the guest.
Yeah,
Reverse roles.
why not? And today we're going to be talking about lots of things. And this originated from a messenger conversation between you and I about research and like the different types of research and exploring more about that. So this is where the idea sort of came from. Um, so yeah, we're kind of going to be exploring lots of different parts of research and expanding, like zooming out a little bit more on that. Not just research, but like evidence-based practice. What does that look like? Where does it fall short? And what are some of the like misconceptions around it? Um, would that be a fair summary?
I think so. Yeah. Hopefully this sparks some more discussions and reflections. And I'll try to keep it simple. So
Yeah.
I'll rely on you, Victor, to pull me up if I
Okay.
need to
Yes. I'll let you know if
bulky
there's any,
reality shit.
yeah, if there's any terminology that I'm not sure of, or maybe the viewers aren't sure of. We'll be sure to tackle that because I know there's going to be some big words coming up.
Yep. Knowing me.
Yeah. All right. So let's get straight into it. So the first question is, what is research and why is it important?
So research is not Googling and looking through page one results and then just confirmation biasing your way to what you already thought and believed. It's more of a systematic uh, gathering of data and usually with peer reviewed kind of scholarly articles. So things that come to mind would be like PubMed, Google Scholar, or any kind of source that has literature, scientific literature. And importantly, in that process, you have to interpret the research. So it's hard to do research or to research something, and it also depends on the question that you're asking. So I don't know, Victor, do you have like something that maybe students might come across in their studies, or like a typical research question that you get asked or assessed on?
Well, something recent that it's on my list to research is, does knee valgus cause osteoarthritis, or like does it accelerate it? Something like that.
Cool. So that's like a causal question, looking at the link, if it's
Yeah.
like a correlation or direct causal. So then already there's like two topics at least within knee valgus: what that is, how it's measured, how it's defined, in what kind of context. So like knee valgus in a bilateral squat movement versus in a explosive dynamic team sport, chaotic environment. So that's like one topic. And then osteoarthritis has its own research base. So like if you were to research it, you'd have to be aware of what question you're asking, and what the topics are for each. And I'll try not to say ontology, but that's like, the what the fuck, what you're researching. And then that will then decide on how you research or search for the data, the information.
Hmm. So it sounds like you're finding kind of you're creating a concept map almost where you have a sentence or a claim and you're breaking that down into a mind map of osteoarthritis and then not only just mapping it out so it's clear in your head, but also going further, like what is this thing? Like how do we measure it? What's the gold standard? Is it reliable? Is it valid? So I think that's a good way to frame it. I never thought about that before.
Yeah, I think a common mistake is just going through systematic reviews, meta-analyses, and then reading the conclusion, but not having a reflection or thinking about what you're looking for. This is all covered in our decoding science course, through the knowledge exchange, that you could talk about more than me, Victor, because I fucking forgot
Yes.
about it
Highly
now
recommend it.
until I just Yeah, so Tula just mentioned it now, where it goes through like a cheat sheet, I think, of what you're looking for, or what the kind of, um, I guess, question is the methodology, I guess, related to the question, is one of the biggest takeaways from that course. Maybe if there was like one take home from that course, or from what we've just talked about on that, Victor, you can share.
There's, that whole course just has so many things, but that cheat sheet was probably one of the most valuable things in my opinion, because it's like having a guide while you're going through the paper, and just tick things off, see, does this need improvement? Is this actually solid? And then like work your way through it. So I found that really helpful. And like you mentioned, the answering the question of whether the methods actually answer the question, that's a big thing, and it's not something that comes naturally. You need to actually think about whether or not the methods actually do relate to the question. I know I've thought of, when I hear of a claim, the the second thing that comes to my mind is, how, if I were a researcher, how would I test it? And I feel like that's a nice way of looking at it, because then you can see how it matches up with the literature. Maybe you'll be wrong because they've actually done it more than you. But having a just a sense of what type of study design would effectively encapsulate that question, I think that also helps.
Yep, yep. Like if you want to find out someone's um, experience of pain and their suffering, you wouldn't go with correlation data with multiple like quantitative research. You'd look at qualitative research methods. And if you wanted to look at, say, the harm of a drug and side effects, you would need to go through RCTs. You need to go through like systematic quantitative research. As so then the question guides what kind of research is most relevant for you. I think that's probably the simplest I can put it.
Yeah, and then that goes straight to the study design part of things, where there's qualitative and quantitative. So do you mind breaking down those two terms for people who might be unfamiliar?
Yep. So the quantitative is in the word, which is different to evidence-based practice. Evidence-based practice is not just practice based on evidence, whereas quantitative research is quantitative research. So it's like knowledge as facts. The idea that you can observe things, and you can, to the extent that you can measure things. In general, it's seen through the lens that there is one truth, or you can discover things through observation, regardless of who is the observer. So it's like more objective. Um, I think that's the limit that I can go before I go into like the multiple subjective opinions of that. But essentially, it's more objective data. So where it would be helpful, again, is like drug trials. If there's something that can be directly measured, range of motion, strength, and it's very useful in a lot of decision making and policy, to the extent that the results can be generalized to a population. And at the same time, there's lots of limitations within quantitative, with the sample sizes, or the inclusion exclusion criteria of their samples. So for instance, a lot of research doesn't have people over the age of 75. So if you're working with someone over the age of 75, you kind of have to know that the guidelines or the systematic reviews don't include someone of the age of your patient. It's not to say it's good or bad, or that we kind of throw all the quantitative research in the bin. It's more, okay, that's a limitation of the direct observation that we can gather, and what can be measured in a quantitative way. So like RCTs are in this bracket. Yeah, how does that sound with quantitative as a general overview?
No, I think that's a great way you like how you broke it down just then. I think, yeah, I didn't actually notice that quantitative had those limitations, but it's quite obvious. Like obviously there's parts of research that are not studied as much, like how you mentioned the elderly. I never thought of that as a potential limitation. I always thought of quantitative as like, yes, so good, you can answer any question. But yeah, I never thought of it critically like that. Yeah, it depends on maybe the most popular places of research or populations which might not have been studied as much.
Yeah, and some things cannot be, I guess, directly observed or measured, or even the methodologies, the ways of, I guess, coming to a conclusion makes so many assumptions. This is big in pain because pain is a subjective, emergent, complex, personal experience. So already it's not, again, don't misinterpret this as it's shit and don't use any of it. But when we have a VAS, like a pain out of 10 score, there's limitations to using that already. And so we can't just have pain out of 10. And if it's reduced or it hasn't, then it means the intervention's good. We need to look at things like disability scores. We need to look at things like the qualitative or mixed methods. And yeah, so function changes for someone before and after an intervention, not just number out of 10 for someone's personal subjective experience.
Jeez, that's like broken down the entire way I view my research when I'm looking into pain. Like I'll often look at, I don't know, does X intervention help reduce pain or improve pain? And I'll go straight to the VAS scores, and I'm like, oh, okay, it it works or it's not as effective. But then, yeah, you forget, even though I do know this, that pain is such a multifactorial, massive experience that obviously goes beyond a 1 to 10 scale. I yeah, I didn't think of it that way again. So it's like, yeah, it's hard to, okay, wow. So quantitative research has lots of limitations.
Yep, I could have prepared more for this, but yes, there's a lot.
Wow,
I have
okay.
to like think through some of the specific methodologies. So yeah, there's it's what's the function of quantitative research? It's to look at large scale data because you can't have a semi-structured 1 hour interview with a million people. So it's really good for getting generalizability, for getting big data essentially. So you can make different inferences, and it's a different type of causation. But then if we're looking at something more contextual, we need to look at perhaps more qualitative research or mixed methods research, or at least understanding that even if we have a billion data points, there's still other things missing on the insight, on the depth of the understanding of each of those data points' experience. And like in a practical way, someone getting a reduction on their VAS of 2 points, so they went from 9 out of 10 pain to 7 out of 10 pain, could mean the world to them. That would mean they could go outside, feel less kind of stigma, and feel like they're able to walk further, able to do more things, change of their mood, change of their sleep. So it could be a huge difference, just those 2 points. But we don't see that if we're just looking at it through a quantitative lens. And someone else, those 2 point differences is nothing. Doesn't mean shit. They're still suffering. So they need other supports. We need to look at their experience beyond just a number out of 10.
Mm, yeah. And that's where I'm seeing more of like a mixed methods type of like research design come about.
Yep. Kevin Wernley is a good one that comes to mind. I chatted with him on the Knowledge Exchange podcast with back pain beliefs. And yeah, so he did mixed methods and quite a lot with his PhD. So I'd recommend reading his stuff. He's on Instagram as well. So there's a growing amount of mixed methods. If you talk to a qualitative researcher, there's still some of the mixed methods are done without theory. So maybe that's for a future podcast. But yeah, so mixed methods is great. At least I think for starting points, acknowledging the value of qualitative research. Because I don't remember going through any qualitative research when I did uni. So hopefully you get some exposure in your degree now. It's 2024. You've got some, like Natalia Costa comes to mind at UCID. You've got a lot of people talking about qualitative research. So it's growing in its understanding. It's still seen as below in the hierarchy, which we can chat about, but it's slowly being appreciated more.
Mm. I haven't been taught anything to do with qualitative methods. Well, it's I've only done 1 year of EP, and then now I'm doing the first year of physio. So obviously it's early days, but hopefully, fingers crossed, we'll get some qual in there. Yeah, but the way I was taught generally was that quantitative, like quantitative data with the pyramid, with the evidence hierarchy, with meta-analyses and systematic reviews being at the top, then observational studies being in the middle, and then like animal studies at the bottom. And yeah, it was very, we didn't really cover qualitative at all. And like we didn't even mention the limitations. I feel like a consistent theme I've been seeing throughout uni is they they pitch things as if they're absolutes without acknowledging the limitations. So like same goes with special testing, and then I see it as well in the how they present the evidence hierarchy. They just say this is it. They don't say, okay, this is our understanding. Here are some limitations. Here is where it can be helpful. So it's a bit frustrating to see that how they're not telling the full picture.
Yep, and imagine it might not be the time, the space, the context for those kind of discussions. So hopefully, at least we have these questions of what are the limitations in our mind, because that's something that we can have as a tool. It's like a life hack. Look at criticisms, or look at other ways of viewing something, or look at what's missing from what I'm being taught. And hopefully, like tutors, lecturers are open to emails maybe outside of class time, because there is a rush to cram the shit out of all the content, and also be responsible for a large cohort. So I wouldn't expect like to have a 10-minute DNM conversation discussion about the limitations of quantitative research at your next tutorial. If you do, that'd be amazing. I would want to know who that tutor is, and how they get so much free time. But yeah, hopefully this sparks some discussions on questioning the hierarchy of evidence.
Yeah, and it's a good point that obviously there's a curriculum in place, and it would be annoying to disturb that, especially to the unit coordinators, tutors, lecturers, etc. So yeah, if you could maybe like make the space after a tutorial, after a lecture, if they have the time, yeah, or even an email. But yeah, so we could like work around the system, like spies almost. Um, and moving on to like clinical guidelines, I wasn't taught much about clinical guidelines at all. And from my understanding, it's somebody has created this like recommendations depending on like different populations, different diseases, and they've sort of like summarized the research and presented it in an easy to understand way for clinicians. And you could, as a clinician, you could just read it and then see what like a synthesis of the current available evidence, and then just implement that. That's how I've been taught and like how I've seen it. So I know you wanted to mention a few things about it, but like, how is that definition?
Yeah. My mind just went straight to, I wish it was that simple that we could just implement something, just give someone an exercise prescription and that's it. That'd be amazing. I would love that.
Mm.
So I think there's a difference between like a guideline and like I was going to say gospel, but like a certainty, like a specific individualized recommendation for someone who likely has more than just the condition that's in that guideline. That's all. So it's not, again, the straw man is, are you saying evidence is shit, we shouldn't use any guidelines? No, just recognize the limitations of the guidelines, that they're built for like an overview. They generally go through what not to do, and they influence policy. They look at generalizability with, again, large populations, and it's generalized. It's not specific to the person and their experience, their suffering, their access to care, the time they have for exercise, their language barriers when coming to like education, all these other considerations that are often missed. So guidelines are not designed for that. They're more large scale. They're designed for a single condition.
Mm-hmm. So would it be fair to say that you would take those guidelines and then apply it to the person in front of you and make it individualized in a way that would be comfortable for them?
Yeah, that's assuming that that individual has just one condition.
Yes, okay, okay.
Name me one person who just has one condition in general. I've got like, surely medically, like I'm looking throughout my health history. I mean, I've got, you can see one, vision impaired, that can count as one. But like my history of injuries, I've got, who has just one injury?
Mm.
It's just an example
Okay.
of like the principles. We can still use the guidelines as a general recommendation, absolutely as a starting point, especially when new to a condition. And then we
Mhm.
can build from there. Um, and then look at some of the context, then the nuances for the individual, and what, importantly, what the individual's goals are, which could be completely different from what the guidelines say. The guidelines are just like, this is a condition, this is the diagnosis, this is generally what we see, this is generally what's helpful, this is what we know is generally not helpful. Use it
Mhm. So, but you're not limited to just those interventions that they recommend in the guidelines.
within your scope of practice. Now we're talking like medico-legally, like you wouldn't,
Yes.
you know, perform surgery on someone. Um, but I think yes, it can be a helpful starting point, and I think it's also helpful for the public. I think knowing, like, for patients, clients, if we can have accessible kind of guideline care or recommendations, then at least they kind of know what to expect. But yeah, that's just my opinion on how guidelines can be better used. They often miss out on the person behind the diagnosis.
Hmm. Okay. So then how would what could be some improvements maybe to the guidelines?
Outlining the limitations.
Yeah.
I think that would be by far the biggest rock. The other one is maybe how that we're taught about how to use guidelines, and that goes into a deeper topic of evidence-based practice, and that goes into how to contextualize and how, what kind of clinical decision-making frameworks you have when working with a human. I mean, you can talk from observing and working with a shared client that we have, and the different kind of problems that they might come up with. It could change. So you could use one guideline in the first 10 minutes, but then something else comes up in the last, I don't know, half hour of the session, or they have a new condition, or they have a different problem, a different consideration. So it's more of a ongoing dynamic process when working with someone, and you're using evidence as part of that.
Hmm. It sounds complicated. Yeah, it doesn't. To my understanding was that it was it's like the holy grail of evidence. It just gives you everything, but yeah, apparently not.
I wish. I mean, imagine if it was that simple.
Hmm. A patient could just look it up and then do whatever intervention it says. Like if it's some exercise, do this exercise. But yeah, it's not like that.
But what happens? So many things. Like
Hmm.
you can even think of just imagining like a exercise program. You'd still have, very much, there'd be a percentage of people who that would benefit. And there's research Mitch Gibbs has done on like personalized low back pain prescription versus non-personalized or generalized, and there's not much difference. So there's still going to be some benefit, absolutely. Um, it's when it doesn't work. Why doesn't it work? Because life, because they're a human, they're not a robot, they're not one condition. Their condition naturally changes, the level of suffering they have for that condition changes, all these other factors. So it's like, if you want simple solution, complex systems, complexity thinking,
Hmm.
not direct causal line thinking. I had a chat with Soph Shepherd, who's a PhD candidate and a titled pain physio, on the Knowledge Exchange. It should be the latest one out. And she touches on this. It's like we assume it's a cause and effect, like a linear reductionism is how we're taught. That's very useful in things like cancer, when there is chemo and radiotherapy, or things like an infection, you get, a drug for it, or, you need fucking insulin for diabetes. That's like, yes, linear cause effect, absolutely. It's more when there's a combination of things happening. It's never linear. Looking at injury and rehab, it's non-linear. You don't just, naturally get better day by day in a constant state. Very rarely. It's more like up and down. You get flare-ups. You get some days you feel amazing. And another thing that is a good one to reflect on is looking at sports performance or motor skill acquisition. It's never like you just naturally get stronger every time. You just increase the weight on the bar by 5 kilos every single session.
I wish.
Exactly. So again, the theme, hopefully people take away is look at the limitations. What are the limitations of this?
Yeah, for pretty much every point we've discussed today is look at the limitations and I guess bring you back down to reality, because very often we can get caught up in thinking that something is more than it actually is. And it's not our fault. It's probably because we were taught that way, or we were presented information where it seemed that way. So it's not our fault, but yeah, I guess having that critical lens and asking what are the limitations of this can help.
Yep. And there's limitations to qualitative research. You can't make generalized statements in general. You have to kind of transfer it. And then there's reflexivity and using, okay, the theory of this qualitative research, how does that apply to me in my context with my patients? Which ironically is what we should be doing for everything. But that's another podcast. But there's limitations to a lot of methodologies. And just recognize the function, the purpose of guidelines, for instance. They're not for a cookbook. They're not like you just do this to someone fixed. That's how it's assumed, that it just has all the answers. No, there's limitations.
Okay. Well, that brings me on to the next part that I want to talk about, which is evidence-based practice and evidence-informed practice. And evidence-informed practice was a new term for me. So I was wondering if you could break down those two terms and like really describe what they mean, because I think I understand, but maybe not.
Yeah, so evidence-based medicine, evidence-based practice has a history. I'd recommend going into it for essentially trying to see how practice can be standardized across different cultures and countries and languages. So, you get a similar quality. So it's like quality assurance. Kind of like if you have a 10-year uni degree, you'd hope that there is a sense of safety. You can trust that they've gone through some training. So if we have systematic, tested knowledge and data and information, then we can use that and we can build from that. Evidence-based practice is generally following a hierarchy of evidence, and it's very good as a guide. And we still have to kind of critically appraise the quality of the evidence, but it is a starting point. Now, it's not just the evidence, so that's the biggest misconception. It's combining our clinical experience, I would argue just our experience in general, and the patient's needs, their context, and their goals. So if that's the only takeaway from this entire podcast that someone gets, I think that's perfect. Evidence-based practice is combining all of them. So it's hard. It's not simple. It's not linear. It's not cause and effect. And yeah, so again, general guideline, standardized practice, and very helpful for moving the field forward. The emerging term evidence informed was looking at the context. So if you can think of the evidence hierarchy, it generally focuses on the systematic reviews, meta-analyses as the most valuable kind of evidence, whereas evidence-informed practice would acknowledge the limitations of evidence-based practice. And given the limitations, instead of this hierarchy, we've got a landscape of evidence. So I'd recommend looking up Matthew Lowe and Laura Rathbone for a lot more in-depth and better explanations of this. Essentially, it's bringing in all forms of evidence according to the person and their context. And instead of this hierarchy, it's leveling out the playing field and using all available evidence according to the dynamic process of working with a human. So it's not negating the hierarchy. It's just like being like, hey, there's a lot of limitations. Maybe instead, for this person at this particular time, we don't have fucking systematic reviews, meta analyses for this population, for all their comorbidities, for their needs, for their socioeconomic status, for their age, for their gender, for their location. They're in a rural town. Fuck, we don't have research on people in a rural town. We can't do anything then. No, you can. It's just using it based off what we know from the landscape, the whole body of evidence, as opposed to just looking at valuing RCTs or systematic reviews only. Spoke a lot. Does that make sense? Can expand on some points.
That does make sense, but to me they sound like two different, like evidence-based practice and evidence-informed practice sound like two different approaches. Would that be fair to say?
They both have evidence. One is more flexible with how it acknowledges the limitations and the value of rather than the value, the applicability, how you can apply the evidence to a specific context or a population or a circumstance. Whereas evidence-based practice, it still values evidence. It just looks at it more through, I guess, generalizability and guidelines and large scale. And it uses, you would say, more value is placed on data points and what can be observed. So it's kind of like a progression in a way. There's arguments as well. So don't take this as like, this is the answer. Like look it up yourself because there's arguments on kind of, there's still debate, ongoing debate and consensus as to whether we should all kind of start using evidence-informed practice, because the way that evidence-informed practice is used in marketing is different to how the researchers use evidence-informed practice. So yeah, I'd say one difference would be evidence-informed is kind of a progression if we're looking at historically as a timeline, and it involves more of the value of the context of the specific patient population and the circumstances for individuals.
Interesting. Yeah, wow. So yeah, so this must be relatively new then. The fact that people still haven't decided if we should jump ship to evidence-informed practice. So would you say that evidence-informed practice is, I guess, more helpful? Well, it sounds like a bit of like the progression of the biomedical model to the biopsychosocial model. Would you say it's like akin to that almost?
Yeah, evidence-informed practice, it's at least this is n equals one from the marketing and what I've heard from clients, patients, experiences with clinicians who use evidence informed over evidence based, is they just do whatever the fuck they want. So it's almost like they skipped what the actual definition of evidence based practice is. It's not evidence only practice, but they think it is. So they just, you can just use a term, you just make shit up. I can call myself biopsychosocial, psychologically informed. It's just a
But are
word.
you? Yeah.
Exactly. Yeah. So I can call myself evidence-based practitioner. Sure. You'd assume so. You'd hope so. But am I? Don't know. Depends on what evidence are we talking about.
Help me
Relations.
understand. So obviously the evidence part, I think it's the most comfortable part with that whole framework. And I feel like a lot of people would understand that obviously evidence, searching out articles, understanding that, that's fine. But then in the domains of the patient and the clinical experience, tell me a bit about that, because I'm not sure how that would fit into the picture.
The best is using your own experiences and reflecting on them. So maybe we won't name him. We'll call him Bob. Let's call, you know who I'm talking about, our shared client, Bob.
Yeah.
How would you say, what would you say is like evidence-based practice for Bob?
What would I say? Well, considering he doesn't have any well specific conditions or anything like that.
History
Um,
of.
yes. Uh, maybe because his goals are more in like the hypertrophy range, maybe that would be more specific to him. So like how to best like what kind of like sets and rep scheme and what kind maybe types of exercises might bias hypertrophy and strength more perhaps. That's what I would see in the evidence part of things.
Yep. So you would use the evidence of, as you mentioned, resistance training, hypertrophy, um, programming, those kind of things. Anything missing? Is yeah, we could call this say Gen Pop,
Yeah.
even though yeah, back pain
Okay.
history.
Okay.
Yeah, cool. And so what's the next step with evidence-based practice? We've got clinical experience. So
Yeah.
what's your experience and understanding and interpretation of the hypertrophy literature?
Or my so is that my understanding just without looking at the evidence, like my biases, or is that after looking at the evidence?
Always it's and that perfect. We this is if we can pinpoint this part, this question, this is where people get confused or they misinterpret it. It's a using evidence.
Hmm.
It's not a fucking binary. Get pissed off all the time because it's so misrepresented. It's your interpretation with your experiences and the evidence.
Okay.
So,
So it's my experience. Okay, so it's with okay. I'm just having trouble. So it's my experiences, and obviously I've had experiences before of like personally me maybe trying to do some sort of exercise program. Is it like what I've been doing then?
yep. And what have you heard and seen?
Okay, so like from social media and that type of thing. Yeah, so
Yep.
like I don't know, let's say people say training to failure increases hypertrophy.
Sure. You've seen that. And so you're constantly filtering the knowledge, the information from your lived experiences, from other people's so vicarious experience, from, as you mentioned, podcasts, from your kind of social circles, from what you've seen, from what you heard. So everything. It's like your direct observations are included because your direct observations are the lens that you see things through.
Hmm.
You can't discount your experiences. And you've got like 18 plus years of experience, of life experience. You can use that. You can use all of that depth and richness and reflect on it. And even if you don't, you still have it. So combine it with all the evidence that you've seen and come across on hypertrophy.
Okay,
It's both, it's building.
so in a way it's like okay, it's both you're combining them both just to give you a better understanding of where you're at and perhaps an opportunity to check your biases when you compare the literature.
Yeah, I mean, comparing it often comes with like it's a either or it's like a debate or it's like my experience over the evidence. It's more what are okay, maybe a better way is what are the limitations of the evidence and what are the limitations of your experience?
Hmm.
Combine them both.
Okay. And then also the way how you see things might not be too different from the way the client sees things because we both might be on social media and see that claim that training till failure increases hypertrophy or something.
Yeah, sure. So that's
Yeah.
within your experience. And then combining those two, it's really hard. We don't get enough like felt experience of how it's like to combine two ideas and especially when they're like different or we thought that
Mm.
they were separate. So assuming we've combined them all and it's complex, it's like Play-Doh, when you have different colors, it becomes a new color. So you've got that. And what are the patient's goals?
Hmm.
What are their preferences? What's their training history, medical conditions, etc.? Combine that all together. That's evidence-based practice.
Yes.
Dynamic, it's complex. Combining it all brings a new product. It's not just the sum of its parts.
Hmm. That sounds really like hard to apply in
So
practice.
examples
Yeah.
practically are the best. You can't just go to a course that has all the evidence and be like, cool, I'm confident, sweet. No, you missed two parts. What about your experience with it? You have to practice it. You have to make mistakes. You have to reflect on your mistakes. Supervision, mentoring, psychologists have it all the time. So it's like you need colleagues, peers to bounce ideas, and you need humans. You need case examples. Case studies are okay. They often just miss a lot of context, but you need to see, okay, how do you interact with someone who believes in the opposite of the evidence, for instance?
Mm.
That's also evidence-based practice because you're still using evidence. So examples of interactions and also reflections like, hey, experienced clinician that I have on placement, what did you think? What were you thinking? What was going through your mind? So then you have their clinical reasoning, like the background of all the things that they're trying to synthesize.
Mm. So
Yeah,
you can
so
add
it's
on not only your clinical experience, but also use other people's clinical experience to add to that big ball of evidence-based practice.
yeah, that's how we learn. We learn through observation, vicarious experience. We see someone do something like, oh, cool, that's cool. And we try it, make mistakes, fall over, and try it again. Oh, cool. We get feedback from our mistakes and we learn. We start flipping and shit. If only it was that easy. But yeah, combining it all.
Mm. Okay, so now that we have a rough idea of what evidence-based practice looks like, what would be some of the, well, you mentioned some of them already, but some of the like misinterpretations or things that people get wrong when they try to apply or even understand this model?
So I can give a reference later, but essentially, I'm going to quote one of the papers that I've got up um, with 3 points. One, evidence-based practice is, as I mentioned before, a cookbook approach. So you just have like this diagnosis, and it's like an Excel sheet. So if you have radicular pain of this sort, you just have this prescription, and that's the fix. So it's like very linear. Um, that's one misinterpretation. Two is it devalues clinicians' knowledge and expertise. And if you've just been listening to 1 minute of our past 5 minute conversation, hopefully that one's like, you've got an understanding of it doesn't devalue it at all. It values it, it uses it. And three is ironically the other side. It ignores patients' values and preferences. So if I were to summarize it, it'd be it's a cookbook. It's like it's what you do to people. It's the answers. And number two is it is evidence only practice.
Mm-hmm. Yeah, I've
Or
definitely
it's
heard
only
of those.
randomized control trials. Sorry, I have to add that in. That's
Yes,
another thing. RCT only.
I've definitely heard some of those before. And I think I've experienced those where of those like, especially the cookbook approach. We recently had a conversation about that. Yeah, I think yeah, it'll be helpful to. I think this is a chance for me to brush up on my own knowledge of evidence-based practice. I know I've got a few papers in my Zotero box, like waiting to be read about that. So yeah, this conversation definitely taught me I need to brush up on this.
Yeah, it's and there's like posts M Walker underscore XFizz and the knowledge exchange. So Emily did a whole post on it, and it's like the second last slide is evidence-based practice is what it actually is. It's a framework that guides our clinical reasoning and our decision making. It emphasizes ongoing evaluation, so it's not just like a one-off static thing like a cookbook. And it involves integrating, combining research, different types of research and evidence, clinical expertise, the patient's values and circumstances, and the practice context. So all of it.
And
Yeah.
by
So
ongoing, does that mean, is that the way I thought about it when you said ongoing was it reminded me of the clinical reasoning cycle, how we reflect back on the clinical reasoning cycle and ways to improve it. Would that be a similar process there?
yep. And if you reread research, you come up with like different interpretations or you see things differently based off new knowledge, new evidence. So it's an ongoing learning,
Mm.
growing, reflecting, revising, updating. Like before we hit record, I talked about the misinformation research. So now I have to fucking go back. It's annoying. It's a process of being like, oh shit, that was wrong. Okay, now I update it, make it stronger, make it better, improve it.
Mm. So because the evidence is always changing, therefore evidence-based practice is always changing and how that
Yep.
relates to our client.
So evidence-based practice for the best clinician in the world in the year 2022 should be different 2024.
Yes, that makes sense. Cool. So I think that's pretty much all that we wanted to cover today. Was there anything else that you wanted to mention or spread the word about to potential viewers about everything we've talked about?
I think that makes the most sense for like the topics, the process, like a future podcast will be how to reflect and
Yes.
the like examples of reflection. So a lot of the reflection is ironically not given the time space to be like to reflect. It's kind of like you think about your thinking. So that's critical thinking essentially. So I think that deserves a bit more time and like properly thought up with questions, and I can prepare some things as well. And yeah, so the how I think is the biggest thing that
Mhm.
needs to be acknowledged.
Yeah. So yeah, it's one thing to learn these frameworks, which is it's good if you do learn them, but then how do we reflect on that? How do we apply them? That's probably the hardest thing, I would say.
Yep. So practically for students listening, reach out to clinicians, observe, ask questions, just like you're doing, Victor. Email, DM, follow people, see some examples of interactions with patients. That's where you'd learn the most of like an understanding of what it's like to combine research, evidence, experience, and the person's needs in their context.
I think that's a beautiful summary. Yeah, well, thank you so much, Dan, for coming on. And yeah, I definitely need to brush up on my evidence-based practice knowledge. Obviously, I thought I knew what it meant, but now this gave me a completely different look on it. So I think that gives me and potentially a lot of other viewers a chance to like read more about it, find some resources on it, and yeah, really develop our skills in that area.
Yep. And hopefully it strengthens your stance now. I think
Mm,
people think that, oh, that means that I'm wrong or I'm like personally criticizing. No, I used to think the same. So it's an ongoing process of updating your stances, your beliefs, your understanding. And if people need resources, they can DM me and I can send through any resources to you as well.
perfect. Well, thank you so much, Dan. I appreciate it. And hopefully, since you've been such a reoccurring member, we'll have you on for potentially that talk about reflection, because that could be a very good topic, and I'm sure that lots of people would benefit from that.
Sounds good. Sounds like a plan. Thank you.
Done. Thank you, Dan.